Is this better? It should be. Oh. It is on. Well, let's try again. Is this better?
Yes.
Oh, okay. It was on sleep mode. So this is our last medical education grand rounds of the year, and it's a fitting way to actually end. So everyone may know Dr. Meah, but I'll introduce her anyway. She obtained her BA at Johns Hopkins and her MD at Harvard Medical School. Then we were fortunate enough to get her to come here to Mount Sinai, where she did her internal medicine residency and her chief residency. Then we were fortunate enough to get her to come on as faculty. And in her clinical role, she's been working with the Visiting Doc program as a physician, and she also is the chief attending physician and the program director for EHOP, the student-run free clinic for the uninsured. She is also the clerkship director for LCE, which they're going to talk about, and now for Interact.
Yeah, it's actually just Interact.
Oh, it's just Interact? Oh, sorry. So now it's going to talk about LCE, and you're going to, okay. And Interact is a new inter-clerkship ambulatory care track, Interact, which Yas has been running this past year. Nell graduated from the University of Southern California with her master's in public health. While she was there, she worked in the Division of Cardiology, helping launch a women's cardiovascular center, which was devoted to meeting the unique needs of women in prevention, detection, and treatment of cardiovascular disease. She also completed her thesis work at the California Family Health Council, working on infertility prevention. She's been here for the last 2 years, helping administratively with LCE and Interact as the coordinator. I'm not sure who's going to speak first. And also, Dr. Soriano has been involved in the program as well. Okay.
So, I'm just going to quickly just segue into Nell. But I wanted to just quickly review the objectives. So, Nell is actually going to talk to the group about the history of longitudinal clerkships across the U.S., which has actually a fairly longer history than I realized. And then we're going to talk about the mission, development, and implementation of the longitudinal clerkship here, which was an outgrowth of LCE that Val Parkis has headed. And then we're going to take some time to reflect on a lot of the barriers to implementation, some of our outcomes and lessons learned, and then talk about the future directions of Interact. Okay.
So when the initial committee came together to develop Interact, they first looked at all the clerkships that have been implemented over the last couple of decades, and many of them are actually rule-based clerkships. So today I'm going to talk about three main ones. One is the rule-based program at University of Minnesota. The second is probably the most well-known and written about clerkship, which is the Cambridge Integrated Clerkship at Harvard Medical School. And finally, to kind of give more of a broad perspective, we're going to look at the UCSF program. It's for an active integrated student clinical experience. And the UCSF one probably is similar to us because they're also an urban academic medical center, so I thought it would be good to look at. So the Minnesota program was started in 1971 through a state-funded initiative. The state of Minnesota wanted to increase the number of primary care physicians going and serving rural Minnesota. And they've been continuing to fund the program because of its success and the number of primary care physicians they've been able to produce. The main objective of the program is for students to follow the course of a patient's care through the patient's primary care physician, and through that they also team up with specialty clinicians and other primary care doctors who provide services for that patient. It's a 9-month structure. It's been 9 months since the beginning, and the students are basically paired with a primary care mentor in a rural-based community, and all students are self-selected. They volunteer to be in the program. Average, have about 33 students per year participate and complete the program, but it ranges between 19 and 46 depending on the interest in the class. They're mentored by the primary care physician, and they're able to see a full range of rural primary care, but are still able to meet the third-year clerkship requirements, which include surgery, women's health, pediatrics, emergency medicine, orthopedics, and neurology. So because of the widespread aspect of the clerkship, many of the clinics are throughout the state. The core curriculum is online based, and it covers all aspects of rural healthcare systems, healthcare management. They do evidence-based, end-of-life care, and community health assessment. But in addition to the online curriculum, the students all have to complete 2 projects, one being an evidence-based practice report where they investigate the literature on a clinical question. And the second, which I think is very interesting, is that they partner with stakeholders in their specified community to come up with a plan that addresses the priority health issue of that community. So if it was at Sinai, we'd probably do asthma, something around that. Since it's been around for 40 years, they have a fair amount of data to look at for outcomes. Up to date, they've graduated about 1,200 students through the program, 82% of which have gone into primary care specialties. They define primary care specialties as internal medicine, family medicine, and pediatrics. 68% of which have gone into family medicine. To look at their students' outcomes, clinical outcomes, from 1996 to 2006, they looked at NBME subject exam scores and fourth-year OSCE scores, and they were able to show that there's no significant differences between the students in the rural program and the traditional students, except for the OBGYN self-exam score. And once they have discovered that, they've made adjustments to their curriculum in order to address the issue. So this is also from the same study that spanned from 1996 to 2006. It might be a little hard to see, but the line at the top is the percentage of students who graduated in math and primary care programs through the RPAP program in Minnesota. And if you look at the second line, this is the national trend for primary care residents, because RPAP program has actually been able to negate this decline. So the second, yep. Yes. So it's obviously self-selected as interest in primary care or rural medicine.
So they may have been already
and also, if I think the University of Minnesota in general has a higher percentage of students who graduate in primary care. So this is Minnesota in general, and this is students in RPAP. This line is the national average.
I think I read carefully they didn't take psychiatry in their third year. Is that right? If there was no psychiatry rotation?
Right. Yes.
Right. It's all integrated. It's completely integrated into their longitudinal curriculum. So all these specialties are basically modified into the ambulatory care curriculum into a longitudinal ambulatory care curriculum. So they don't have a siloed psychiatry book.
But they are getting it.
But also, it's only 9 months, so they have the rest of the year and the fourth year to complete other clerkships. The class size of Minnesota? All of Minnesota? I don't. There's average of 33 students that participate. I don't. I don't have that data.
No, it's a state school.
I can check and get back to you. So the second school program is the Harvard Cambridge Integrated Clerkship. And the curriculum leaders at Harvard, in order to address the shift in healthcare from acute illnesses to chronically ill patients, decided to develop a third-year clerkship that would allow students to follow patients over time. which is the main principle that is used to develop the entire educational experience. It was launched in 2004, and the unique thing about the Cambridge model is that all clinical experiences are housed within the Cambridge Hospital. So it's logistically a lot easier to pull off. And Cambridge Hospital is a 118-bed primary teaching hospital. Their first year, they had 18 volunteers. Again, it wasn't, Yaz will talk about it, our students have to go through an application process, but so far the programs we looked at have been volunteered. So from those 18, they did a lottery and they selected 8 randomly to participate. Students are paired with preceptors in internal medicine, neurology, OBGYN, pediatrics, and psychiatry. And they spend 5 to 10 hours per week or alternating weeks, depending on the specialty, in these ambulatory care sites. And to work in radiology, they have a year-long teaching radiologist that works with them. In addition to that, they have lectures in the beginning of the year in pathology and radiology to kind of build that clinical skills work. They spend 6 weeks with an attending surgeon, and they're encouraged very early on in the first few months to build their patient panel. And they have a kind of a strict criteria of like what types of patients to include in order to meet the ACGME competencies. So I don't know if you guys can see in the back, but this is what a sample week looks like for a student in this clerkship. The first hour of the day, they pre-round if they have a patient admitted at the hospital. They spend the next hour rounding with an inpatient attending. And then the majority of the day is broken into half-day blocks from 9 to 12:30 and then 1:30 to 5. And they basically rotate through various outpatient sites. Neurology for the first half of the year, neurology and psychiatry for the first half of the year, they go every week. And then for the second half, they alternate every other week. OBGYN, they go alternating weeks from the beginning of the year. Medicine and pediatrics, they go on a weekly basis for the entire program. And then they have hours to the side of self-directed learning, and finally they have tutorials and social science curriculum on a weekly basis. And then they spend the evening post-rounding if their patients are still admitted, and they spend one weekend at the emergency room and 1 week night. So their curriculum is based upon case-based tutorials, which the topics have been pre-selected by a curriculum committee brought together, reviewed the ACGME competencies, and picked topics that they thought must be addressed in tutorials. But the interesting thing is that they actually pick they take patients from students' actual panels and they present the case. So if the topic is hypertension, whichever patient best represents that topic, they use that as the example of the week. And the complexity of skills used in tutorials and in clinics increases progressively over the year, and students have they've responded well to that because they felt they can focus their learning depending on the complexity. As I mentioned, radiology and pathology didactics are worked into the curriculum early in the year. So for outcomes, again, they look at NBME subject exam scores, fourth-year OSCE scores, and their first pilot year, they selected 11 students as a control group. The 11 were mix of students who did not get selected for the clerkship who had volunteered and students in the traditional track. So when I talk about comparisons, they compare students from the pilot to the control group and to the entire traditional class body. So there wasn't much of a difference on NBME, and in some cases the students in the pilot program actually performed better. Specifically for OSCE's communication skills, they found that students in the pilot program had higher communication skills. And another innovative approach that Harvard has is that they look at the decline in patient-centered attitudes of medical students. And I'm sure many of you are familiar that as students progress through the 4 years of medical school, their patient-centered attitudes decline. and the biggest decline is actually seen between second and third year, which is kind of ironic. That's the year they deal with most patients. So prior to the start of the clerkship, they had distributed the Task of Medicine Scale, which is a survey that assesses the medical student patient-centered attitudes. And the traditional group and the control group both declined as is normally seen, but the students in the pilot program actually had an increase in their COM scores. Any questions about the Harvard program? So finally, the Pisces program at UCSF, which I think is similar in a lot of ways to the Harvard model, but it has enough differences that I thought it would be interesting to look at. The guiding principles behind the clerkship are continuity of patients, population, relevant core curriculum, continuity of site, learning about healthcare systems, students having an authentic role in patient care, being mentored over time with the same preceptors, and having experience with undiagnosed patients. Again, it's a year-long program in the third year. The first year they launched in 2007. They had 8 students, also randomly selected. Due to positive feedback from faculty and students, they were able to increase their student size to 16. The difference between this program and the Harvard program is that it actually takes place at 2 urban medical centers, Parnassus and Mount Zion, and then outpatient community clinics throughout San Francisco. And similar to the Harvard model, they're asked to put together a panel of patients, but theirs is relatively large, 50 to 75 patients in their panel that they follow over the year. Again, this is the core elements of the program, which is very similar to the guiding principles, but just one thing I wanted to add is that they worked in an inpatient immersion, which I will get to, and ED and OR call sessions. So some of the literature shows that when students have longitudinal clerkships where they're only in ambulatory care sites, they aren't able to experience the working relationships in the wards, how to deal with attendings and the working relationships between residents, fellows, and nurses. So to offset this and to prepare students for residency, UCSF worked in a couple of inpatient immersions, not very long, but a few, obstetrics for a week, internal medicine for about a month, and surgery for 2 weeks. And another highlight that UCSF likes to show is their longitudinal curriculum, which they call the Pisces School. It's about a day to half a day per week, where they go through reflection sessions, stress rounds, palliative care, and hospital system sessions. So I'm going to show you 2 sample weeks from the Harvard program. Very similar to from the Pisces program. It's very similar to the Harvard program that they round in the morning in medicine and surgery, and then they rotate through ambulatory-based clinics again. But they actually have a very large amalgam of different specialties. They have peds neuropsych like Harvard did, but they also have subspecialty surgery, anesthesia, operating room, urgent care. So they actually work in a few more specialties. And now I haven't seen much on numbers from the from the Pisces program, but they do report that compared to the traditional track, their students are more satisfied with faculty teaching, observation of clinical skills, feedback, structured didactics. They perform better on NBME self-exams. And because it's not a primary care focus, their students actually match in a full range of specialties for residency, and their faculty have reported that they have higher satisfaction teaching these students than they do teaching students in the traditional track. So that's it for the history of longitudinal programs, and I think I'm going to turn it over to Yas.
So now I'm going to talk about the experience at Sinai. And just to go back a little bit through the history of programs in the U.S., one of the criticisms. There isn't a lot of literature, actually, on longitudinal clerkships, but there's definitely emerging literature. And certainly there's a lot more coming from Cambridge and now from Pisces. But Paul Hemmer, who is a leading expert in medical education, he's one of the front runners of the Ryan schema for defining how students progress. They, in learning, and that's the reporter, interpreter, manager, educator schema. Paul Hemmer has actually been a critic of longitudinal programs, longitudinal clerkship. His argument is that not learning in silos, and essentially when you look at these programs, the majority of these programs, their median weeks that students actually spend in these immersion programs are, can anybody guess without Pete? Not Pete, since I told them this morning. But can you guess how many weeks students actually spend in these immersion ambulatory care programs, these longitudinal programs? How many, on average? 2 weeks? 2 weeks? Anybody else? These are longitudinal. So these are basically clerkships that are running the entire year. Yeah, that's just exactly. Anybody want to venture a guess? How many weeks? 8 weeks? Yes. Yes. When you add it up, the median, and I'm talking not only across the U.S., but actually internationally, because this is actually an international movement. And so there are approximately 17 to 18 programs. We may be number 19, I think. So across the world, the median number of weeks that students who are on longitudinal tracks actually spend, and these are longitudinal integrated tracks. It isn't just longitudinal tracks which have clinics once a week. These are immersion experiences, true immersion experiences. The average number, I should say the median number of weeks is actually 40. So, and just to try to give you a sense of where we are, we have an immersion experience that lasts 8 weeks. 8 weeks that's eventually going to grow to 11. But we're nowhere near 40. So you look at Cambridge, you look at these other programs, they're anywhere in the 30s to 40s. So these are really, I mean, basically what they've done is they've completely transformed their third year to move from the inpatient setting to the outpatient setting. Okay, and also not only are they moving to the to the outpatient setting, but the students are actually in different disciplines, not only in different days of the week, but on different, basically in the morning they may be in one discipline, in the afternoon in another. And so what Paul Hemmer has argued is that this is not the way medicine is actually practiced, and that there is a value to having students immerse within an actual specialty with mentors, or I should say with specialists in the field. So, for instance, take a month of psychiatry, learn psychiatry really well, okay? The same with OB. Immerse yourself in OB really well rather than this sort of jarring clerkship structure. This doesn't make sense, and this is not necessarily the right way or the best way to train medical students. There have also been a lot of criticism, not so much criticism, but we can just imagine that this is a logistical nightmare in many ways. I mean, I have to hand it to Nell and Val for figuring it out last year. I mean, it's a logistical nightmare to acquire this many mentors and this many sites for even for 8 medical students or 12 medical students, which is why all these sites really can't accommodate many students. I mean, it's amazing that the University of Minnesota can actually accommodate as many students as it can, primarily because their outpatient clinics, they've got so many more. But when you're working in a place like Cambridge, which is a lot smaller, you can't really accommodate the entire 140 students that actually go through Harvard every year. So it is a logistical nightmare, and you can't. It's going to be very difficult, or I don't think anybody would really advocate pushing this to the entire curriculum. But for those students who are attracted to either caring for chronically ill patients or attracted to primary care, this structure does make sense. But whether or not these structures work for us is really a question we had. So we came up with an amalgam, and I will say that, so a few years ago, Val headed a think tank of medical educators and experts in medical education, basically, here at Mount Sinai. A lot of them were clerkship directors, but not all of them. And basically, the mission or the idea was to develop a longitudinal clerkship that was different from LCE 1 and 2, in that this would really be a clerkship experience where, again, students would be immersed in caring for patients over the course of a year and really be the front runners, okay, or sort of be the primary care docs, essentially, for these patients. The members represented multiple disciplines, and many of them are actually here in this room. And it had achieved a lot of momentum over the course, I think, of like a year or two, right? So the mission, again, fairly similar to all the other longitudinal clerkships that we've seen. It was basically the goal was to partner third-year medical students with the chronically ill and have medical students really watch and involve themselves with patients who actually suffered from chronic disease and watch them and participate in the care of patients over time. Longitudinal mentorship with faculty was also a key piece, again, also a key piece in all these other clerkships across the country. There was also a definite focus on ambulatory care. Advocacy was a strong piece that was emphasized. And working with disadvantaged populations became one of the foremost goals. So I'm going to bring here then the marriage of EHOP because I joined the group late. And I joined the group late, but I think that there's something to be learned from what was happening at EHOP at the time. So EHOP is a student-run free clinic of Mount Sinai. We've got a couple of students here who are actually very involved with EHOP. The clinic was actually the first venue at the medical school in which students representing all years were actually caring for patients longitudinally, and they had been doing this since 2007 when EHOP had initiated a chronic care model. It wasn't a curriculum, and I wouldn't call it a curriculum necessarily because it wasn't actually EHOP really wasn't part of the curriculum. It really was a paracurricular venue. So very different from LCE in that it really was operating on its own. So, and there was a lot of investment by the students to care for chronically ill patients because that's what they were seeing. They were seeing a large number of diabetics, hypertensive, diabetics that were completely out of control. And so this was sort of a great opportunity, though, a great opportunity for a marriage between what was happening with Interact, at least the idea of Interact, which at that time was called LCE 3, and with what was happening at EHOP. There was a lot of hesitance, though, to marry the two. EHOP's beauty is that it is staffed primarily by volunteer students. And so there was a lot of reluctance on behalf of EHOP to participate in the curriculum. But it was such a phenomenal venue in that sense because it really allowed for students to follow patients over time. And it was already doing this. And one of the difficulties that was happening at EHOP was that medical students who were volunteering to care for the chronically ill because they were volunteers, they had no protected time. So when they were doing this on their own time. And this was very difficult, particularly for third-year students who had absolutely no protected time to do this. And so as a result, we were really sort of losing out. So the marriage was actually very convenient in many ways. And so this sort of struck up the model or the idea behind what could happen with Interact. It wasn't the venue, but it was one of the important venues that we thought would really propel Interact to sort of the next level. And so with a lot of momentum and a lot of work by Val and Nell in recruiting a lot of these sites and a lot of these mentors, They spearheaded this initiative. And it started in July of 2010, and we had recruited approximately 12 students. I'm going to talk a little bit more. I'm going to go a little bit through the selection process. So 12 students were selected out of a group of 30. They were competitively selected through a fairly rigorous application process. There were definite student criteria, academic criteria that were fairly rigorous. And the reason why is that the idea behind Interact, it was so periodic throughout the year, and we really had to pull these students out of the normal sort of lottery, that we had to ensure that these medical students wouldn't have problems with their self-exams. And remediation for step 1 actually takes place during the 3rd year and could really, really mess up the entire schedule. So we had to be very, very careful about which students we selected. We ended up actually taking 11 of those students, 11 of 12, because one of the students actually failed to meet one of the criteria. Just going back, the implementation was, and I'll talk a little bit more about the schedule, was a fairly expansive multidisciplinary approach, but not nearly as expansive as, let's say, the Cambridge program or the Pisces program. But we did have multiple disciplines represented. For instance, OBGYN was represented. Some of the specialties in medicine were represented, such as HIV, liver, and hem-onc. There were, in general, there were actually a number of non-traditional ambulatory care experiences. For instance, EHOP was one of them. And this is, by the way, the first time that a student-run clinic has actually become part of the standard curriculum. And so Interact really was sort of innovative in that sense. There was also a DOH piece to it. So the Department of Health had an asthma program where students would actually go to patients' houses and also to the hospital and actually work with children who suffered from asthma and go through with them an entire almost curriculum with these patients on how to use their meds, how to control their asthma. And this was sort of one of the non-traditional pieces of the program that were considered a novel piece of any curriculum, and so it was adopted. Visiting docs was also adopted into the program, and again, although it is now part of the traditional curriculum, it had never really been. It's sort of non-traditional in a sense, in that it's homebound care. We also had a lot of traditional ambulatory care experiences, such as IMA, PEDS, and PEDS FTA practice, and like I said, limited specialty clinics. So let me go through, this is not the clearest, but let me go through the Interact year schedule. So Interact actually truly is inter-clerkship, okay? So it periodically happens throughout the year for all our students. And what we did is we took ambulatory care blocks that were in the traditional clerkship and we substituted them with Interact. A traditional week looked like this. Okay. So a traditional week, for instance, there would be a morning in PEDS, an afternoon spent with the DOH asthma program, a couple of afternoons at FTA medicine or a couple of afternoons at IMA medicine, one half day at visiting docs. For some students, not all students, they would have one day at EHOP. So it was a mix of specialties and primary care venues. The primary care venues being obviously pediatrics and medicine. And the specialties being OBGYN and some of the medicine and pediatric specialties. Okay. So in terms of being sort of a novel clerkship, one of the things that was all, well, there are many things that were fairly novel about this clerkship. other than just being a longitudinal clerkship, scholarship was being emphasized. And so one of the requirements for all students was that they had to engage in a scholarly project. And this could take the shape of a research project, a case-based report. It ended up transforming as the year went on, but I'll talk a little bit more about that later. The curriculum was also quite different. When I mean the curriculum, I mean the actual didactic curriculum. The didactic curriculum was different than what was in the traditional clerkships, in that there was an emphasis on the cost of care, on the care of the vulnerable, and most importantly, this was the only clerkship where PBL-based learning was really the focus. So problem-based learning was really incorporated into this clerkship as sort of a major piece of the clerkship. And so all the requirements of ambulatory care peds, ambulatory care medicine were now incorporated into these PBL cases. It also obviously was innovative in that it was the first interdisciplinary clerkship where multiple disciplines were working together and teaching students longitudinally. As I already said, it was the first clerkship to incorporate 2 non-traditional venues. Just overall across the country, this has not been done before. So having an asthma DOH program, and just in general, having a community outreach program as part of a clerkship is very novel, and then to have a student-run free clinic is also very novel. It hasn't been done before. And most importantly, frequent feedback was really the essential driving force behind all of the changes that happened through the year. We had frequent feedback sessions with both students and faculty, and really this is sort of critical when you've spearheaded a new curriculum. You have to have frequent feedback, particularly something that's so complex as this. Yeah. Yeah. So the majority of preceptors actually come from, they're actually the clinical faculty already recruited for Interact. Yeah. So it depended on the venue, or I should say the specialty, but for medicine, we used med-peds faculty and medicine faculty, obviously, who were already clinical preceptors. And then for pediatrics, obviously, we used peds or med-peds. A lot of the faculty are actually sitting in this room. And so they engaged in both. And the learning, the didactic sessions were not just PBL-based, but they were also case-based. Okay. Let me go on. So problems with the design. And in essence, everything that's new always has problems. And in general, everything that's old also has problems. But in particular, it is much, much more problematic when you're dealing with something new that's never been tried before. I don't know if it's really a good way to sort of frame it as problems necessarily, but as things to kind of consider changing is maybe a better way to put it. So the real challenge, I think, in all of this, and certainly for longitudinal clerkships across the country, is finding the right venues with the right mentors. And what we found is that, in general, venues with the right mentors but with the wrong patients, the wrong type of patients, didn't work. So, for instance, FPA Pediatrics, where they see a high number of non-vulnerable children who don't need a lot of advocacy, but they have phenomenal mentors, didn't work. Okay. Maybe, yeah, exactly. But those venues that service the vulnerable but didn't have proper mentorship also didn't work out very well. So the asthma DOH program, unfortunately, there wasn't a great deal of mentorship, and as a result, this also didn't succeed. Yeah. Yeah. So it didn't work in that. So from student feedback, essentially, the population just wasn't right. The students felt like they had come with a mission. The mission was to service the disadvantaged. And when you come in and you're dealing with patients who are not coming from disadvantaged backgrounds, where the advocates are actually the parents and not the clinician, and oftentimes the parents didn't actually want students in the room, so the students were actually shadowing quite a bit. And actually, we have a couple of students here who may have had those experiences that they can reflect on. John and Dimitri are actually our Interact students. Yeah.
So I'm confused with two issues. One is the parents didn't want the students. I can understand that, and that's what I thought Dr. suggested. But the other question is back to the goals of the program. I understand that it's closely tying advocacy and vulnerability, but why did you pick that out as a goal for this program?
Yeah. Rather than just ambulatory care.
Right.
Yeah, exactly. And so that's a really great question. Part of it was spurred by EHOP, to some degree, but part of it was that we felt that it was the mission of the medical school to service, and that although this is not truly a service learning venue, this is not, because students, there are pieces of a service learning venue that you have to have that to qualify as a service learning venue, but in some ways, that was actually a piece that we thought was critical. That we thought that we wanted to attract students that were not necessarily drawn to primary care. And in fact, that was never, at least initially, that was not our goal. Our goal was not to attract students that were drawn to primary care, although inevitably that's kind of who we got. But it was really to draw in students that were attracted to service and servicing the vulnerable. And that's always been, we wanted that to be our focus, which was different in many ways from the other longitudinal clerkships across the country, but in some ways the same. So if you look at Cambridge, for instance, their goal wasn't to show students how to service the vulnerable, but because of their patient population, it was sort of embedded. It was sort of one of those hidden curricula. And what we wanted to do was take that sort of hidden curricula or that hidden goal and bring it to the forefront. Instead of saying instead of thinking that, or that's where we'd like our students to be, we sort of brought it to the forefront and made it not hidden, but a true goal. And people can argue with that, but that was what we felt was the mission of the program. We feel that Mount Sinai is actually changing. I don't know if it's changing, but it's always serviced the vulnerable. And certainly it's become much more apparent to medical students, and certainly who we're attracting to the medical school are people who have worked with the vulnerable or feel attracted to caring for the vulnerable. I think one of those pieces that I think one of the proofs is actually EHOP, but it's not the only thing. So we wanted to give that opportunity to students. Now, people can argue, well, if you wanted that, why did you even choose a venue like FPA? And that's a fair argument. However, we were also desperate for sites, and when you're desperate for sites, and you're trying to put a program together like this, you gotta take who you can. And you know what? The biggest thing we thought, or the most important piece of this, we thought was actually going to be the mentorship. And
who has enthusiasm would carry the day.
Right, exactly. We thought the mentorship was going to be key, and it ended up being one of the key features, but not the only thing. And I think that was a lesson for us. Just a couple of other learning, or some of the other things that we've learned is that our emphasis on scholarship actually became impractical. One of the things we realized is that, first of all, we'd put a lot in these medical students. We didn't realize that actually, well, I don't know if it's that we didn't realize, but certainly it became pretty apparent that when the medical students were involved in these weeks of Interact, they were working damn hard. And I think there's a misconception out there that if you're in the ambulatory care sites versus you're on the inpatient wards, that it's going to be a lot harder on the inpatient side than it is on the ambulatory care side. And that's clearly not the case. Yeah.
Based upon what you know about student interest, which is there need to be more practical, for example, to have the scholarship, the interest arising from their LCE experience.
Yeah. Yes. And that's what we're actually inspiring our students to do. That what we're actually doing is we've realized that to have this emphasis on scholarship that's really within located within the third year doesn't make sense. Their focus is on mastering clinical skills, and this was a distraction. And what's that? And we realized it was just too much to ask them to do this. And if you look at Cambridge's schedule, there was so much protected time for independent study. And we didn't give that to our students. We did give some protected time to our students to carry out independent study. But maybe if we had played with that a little bit more, we could have given them time to invest in scholarship. But frankly, I think it was just impractical. I think we realized that our focus should really be on honing clinical skills, not on scholarship. And that scholarship can arise from an experience like this and should be almost like an afterthought or something that you can work on through the year, but not necessarily a focus. There are a couple of other things that we realized, and obviously, just as I said, service and advocacy were sort of lost in certain venues. There were certain venues where it was really difficult to ensure longitudinal follow-up. And we have Kathy Chen here, who is actually one of the faculty who was extremely involved in Interact. And it's great to have her here because one of the criticisms was that OBGYN, that practice, great mentors, but not a lot of longitudinal follow-up, particularly for these pregnant women. The other place where we didn't see that was actually in pediatrics, where and the reason why and I think I think the way to sort of think about these longitudinal clerkships is that these are student-centered clerkships. As much as we'd like to think of them as patient-centered, they are, but they are much more student-centered. And that's the difference between these clerkships and other clerkships, is that the focus really is on the student. And so there are certain venues where you can ensure longitudinal follow-up. Things like places like EHOP, where the schedule can rotate around the student. Visiting docs, patients are homebound. Where are they going? They're not going anywhere. So you can rotate the schedule around the student. IMA just tends to have a frequent follow-up because of the nature of their patients. But pediatrics, in general, you don't have a ton of follow-up, or frequent follow-up, I should say. Right. Only for a brand newborn. That's exactly right. And so, but it didn't mean we should exclude all these venues. And certainly with a venue like OB, what we realized too is that there was too much redundancy. So what was happening on the inpatient side, because we weren't taking the students out of inpatient OB, having this also part of Interact just was redundant. And that was one of the things we didn't want. We wanted to replicate some of the core competencies, but we didn't want, or the core competencies of the other clerkships, but we didn't want to be redundant. And unfortunately, OB was one of those venues that was redundant. So, yeah.
Was that done because you're eventually going to try to get to 36, 40 weeks, or was that done for another reason?
That was our initial goal, not to get to 30 to 40, but to get to 20, yes. And I think eventually, a lot of us have been, the think tank, which has sort of shrunk a little bit, propelled by a grant to the Macy Foundation, in which they really are sort of pushing us to aim for this many weeks. I mean, one of the things we've been considering is how to incorporate other specialties, such as OB, such as psychiatry, such as neurology, which would mean a lot more networking with these clerkships. And it would mean a lot of logistics. That might be the ideal. I'm still not sure, and I think we all question whether or not that should be the ideal. And one of the things we've realized from this year as well, sorry, I don't know why this is not working. Okay. Is that, what was I going to say? Anyway, one of the things we've realized is that sometimes the transition between clinics, from clinic to clinic, morning, afternoon, day to day, was actually quite jarring. And students really found that transition. Now I'm a psychiatrist, or now I shouldn't say that, but now I'm an OB, and now I'm a pediatrician, and now I'm an internist, was very, very difficult. Certainly in the beginning, but I think over time that actually attenuated. So I'm going to actually fast forward a little bit because we're running out of time, and talk a little bit about the design successes. Clearly we achieved, well, I shouldn't say clearly, but in feedback sessions from our students and from our faculty, some of the successes which we had hoped to achieve were actually achieved. And so one of the great things about a longitudinal clerkship is that you can watch students grow, and you can participate in their growth. And that's exactly what we saw. And it's pretty amazing to have this experience as a faculty member, watch these students from their first day in July to the end of the year really grow, mature, being able to take care of patients with progressive independence is an amazing experience. There was definite longitudinal mentorship as well, and what really, really came through this year was that there were mentors that came out of the woodworks that were not mentors in a lot of the traditional clerkships, but who were really valuable mentors and ended up really being attracted to this program as well as to medical education because of this program. There was just a couple of other things, is that there really was a sense among students, particularly in certain venues, that there was real independence and ownership of patients over time. And that was really critical that was sort of one of the critical elements of the program. I think one of the major successes. One of the other things that was launched this year was a career panel, and this is really the first ever primary care panel, career panel that was ever launched, and it was really it was inspired actually by medical students who wanted more exposure to primary care residencies. And historically, when we've had career panels, internal medicine has only been represented by the traditional residencies. And so this was really the first ever opportunity for students who were interested in primary care to really be able to meet other residents who were students here who have matched in primary care residencies and talk a lot about the process. So I'm going to give you a quick raw data because this is really, I think, some of the meat to some degree. So when you look at the subject exams, or the NDME subject exams, because that's what we've been stressing over and over again, and one of the things you see when you look at the literature on longitudinal clerkships, one of the things that's always highlighted is that students in these clerkships don't perform any worse and may perform better on certain subject exams. So this is, the orange is Interact. These are Interact students, which there are only 11. And the blue is Mount Sinai, students on the traditional clerkship. And as you can see, students on the Interact track, just in general, now granted they are self-selected, but in general they were scoring at or above the mean for Mount Sinai. What's that? What did you say? With psychiatry, I know, and we don't even have that represented. So that's quarter one. Sorry, this is quarter two. Quarter two, again, Interact's doing quite well. This is quarter three. Essentially, we're just hovering around the mean, sometimes above, sometimes a little below. And this is family medicine. And so I'm highlighting family medicine here because all of our students, during their Interact 4 weeks that would normally be taken up by ACC, they're actually in Interact weeks. It's the one clerkship that's completely replaced by Interact. During those 4 weeks, they actually are required to take the ACC shelf, the family medicine shelf, I should say. And as you can see, our students are doing quite well. I mean, they're hovering around the mean, if not doing better. And as, you know, again, I don't know if this is a fluke, but as you look at later quarters, our students are doing a little bit better. But, you know, honestly, we're talking about 2 or 3 students, so it looks really good, but honestly, we're talking about a very small number of students. But we're not to be, I think that the real issue, the real thing to sort of take away from all of this is that we're not worried. Our students are doing fine, at least in terms of their self-scores. Now, Some of the other outcomes that we haven't yet reviewed are their clerkship performance on other clerkships, whether or not they're doing better, the same, poorer. And then Compass 2 has been one of the things we've talked about looking at. Compass 2 results have just come out, but we don't. We're still in the midst of working through them, and this may be something that we want to look at to see if our students perform better, the same, or worse on certain aspects of the clinical exam or the clinical encounter. Particularly communication is a key, but the physical exam is certainly also key. All right. I'm going to just quickly go through just a few cases just to highlight some of the virtues of the program. This is a case of student J. Yeah.
I just installed on the fact that there were negative feedback based upon disparate quality of patients versus mentor, etc. But scholarly, going back to Rosamond's point, the rotation may have been lousy, but they learned.
Oh, I wouldn't say that. I think that's really too bad. It wasn't lousy. Yeah.
It was unsatisfying.
I don't even know if it was unsatisfying. I think that there are just problems. Yeah.
They did well.
They did well. Yeah.
These kids were self-selected. They didn't have a shot. They had no failures.
That's all right.
They weren't allowed to have failed any courses. They're probably good exam takers anyway.
But
that's not sign up.
No, it's not unfunny. We have people that fail those.
I think to focus. I think all the clerkship, or I should say, all the longitudinal clerkships across the country have focused on the self-exam as sort of the indicator of whether or not they're doing fine. Yeah, they're mastering the material, but is that really what we want to focus on when you're studying it?
That's not the... Go ahead.
Yeah. No. The service.
No, but the students don't say, that's right. Right.
But that's like the majority of students in general.
Yeah, but
right.
You have to follow this anyway, because the students want to be reassured that they're not going to get disadvantaged by taking this. Correct.
Right. That's correct. Yeah, you're not biasing this. We weren't taking the top of the class necessarily. We were just taking people who were safe.
Right. Fair enough. No, you were taking people who wanted it.
Who wanted it, right. That's absolutely right. Who wanted it for the right reasons. Right. And they were safe academically. Yeah. So, yeah. And what I would say, and one of the things that I was going to really highlight here, and I don't want to spend a lot of time on this, but that there were some things that students did with their patients that were phenomenal. I mean, there was one patient in particular that I was going to highlight here, who was a woman who, for years, had her diabetes completely out of control. For 5 years, we couldn't get it under control. And the student, across the year, basically made home visits, frequent visits at home, family meetings, and got her A1C down from 13, which had been hovering for 7, 8, 9 years, down to 7. And so this is, and the woman couldn't read or write, and she did it. And she did it by various mechanisms. She figured out how to break the code, essentially. There were a number of other instances like this. I mean, there were students who were engaging in end-of-life discussions in the hospital with patients that they had been seeing on the outpatient side that they wouldn't have done otherwise, but they were able to lead the inpatient teams in terms of how to care for these patients on the inpatient side. The success stories are actually pretty numerous. And I would hate to really just harp on some of the problems, because really it was overall, in terms of patient care and patient-centered care, these students were really going above and beyond because they were just phenomenally dedicated. Yeah?
Have you asked some of these kids with these remarkable successes to sort of write journals?
Yeah, and so, I think that's one of the things we have to do, and I think, and we're not yet at the end of the year, but actually absolutely, instead of scholarship, just writing on their successes, absolutely. I mean, one of our students helped make a diagnosis of MS in a patient who we thought had diabetic neuropathy. It's just over and over again, and we call them soft outcomes. There are ways to measure this, and there are scales to measure this, which we'll look at some point. But it would mean actually looking at these outcomes across all students, on the traditional track and on the Interact track. For now, we'd like to maybe consider looking at Compass 2 as a surrogate to see, for instance, if these soft outcomes, or the more meaningful outcomes, I shouldn't really say that they're soft outcomes, but the more meaningful outcomes, which I think are much more meaningful than a shelf score, are, can be measured. All right, I am going to stop here because I think this could go on and on, but any questions? Yeah, I don't know. Yeah. We have John and Dimitri in the back who are, I don't want to point them out as medical students, they're in Interact, and I don't want them necessarily to talk about the, I didn't think they were going to be here, but I don't know if there's anything you guys want to add about Interact or the experience this past year on the spot.
One thing I would just add is I think that the experiences for the students between have been really different.
Yeah.
And I guess I kind of became aware of that during your talk, which is my OBGYN pediatrics experience is one of my best continuity kind of experiences. I opened high-risk OBGYN with Dr. Chen, and then I followed